Hello and welcome. It's my privilege to spend some time with Dr. Sabine Steiner, an internationally renowned clinical researcher in the field of vascular medicine and interventions. Dr. Steiner, thanks for spending some time with me.
Thank you very much. I really feel honored.
So we're going to talk about the COMPARE trial, a very interesting first of its kind study in the field. And before we get into the details, this was kind of your idea. Tell me, what made you come up with this concept?
Well, I think it's really important. We have now drug-coated balloons on the field in our armamentarium for quite a while. And really several drug-coated balloons have proven clinical efficacy compared to standard balloon angioplasty. But so far, we really had no head-to-head clinical trial comparing two different drug-coated balloon devices. And so that was really the background of the COMPARE trial.
And why these two devices? What was it that that made you curious as a researcher and a clinician?
Well, first of all, of course, both devices really showed good clinical results in their respective studies. But these devices are different. They have different paclitaxel dosages. So we are comparing a 2 microgram per square millimeter device versus a 3.5, so a kind of a high dose drug-coated balloon device against each other. But this is not the end of the story. There's much more into these different coating technologies. So we know that these balloons differ with respect to particulates, how much dose is retained on the balloon, what are actually the circulating pharmacokinetic levels during administration, of course. Although some preclinical work for both balloons really suggested similar local arterial tissue uptake and efficacy, we just wondered how these two balloons would perform against each other within a clinical trial.
Very interesting. So it sounds as if not only were you planning to learn a lot about this, but truly impact how patients are treated. So that's what it's all about. So tell me a little more about the design of the COMPARE trial.
Well, the COMPARE randomized controlled trial is a prospective multi-center trial with a randomization in a one-to-one fashion. We included patients suffering from Rutherford class 2 to 4, undergoing endovascular treatment for femoral popliteal lesions. So this is a German trial. 15 centers in Germany participated, and we are really grateful to all our collaborators, of course.
And what was the endpoint, the primary efficacy endpoint?
Importantly, COMPARE is a non-inferiority trial, and our primary efficacy endpoint was primary patency after 1 year, defined as absence of clinically driven target lesion revascularization or restenosis detected by ultrasound. In parallel, we had a primary safety endpoint, which consisted of procedure or device-related death, major amputations, and freedom from clinically driven target lesion revascularizations. The non-inferiority margin for both endpoints was -10%.
And we've had the 1 year primary outcome data for a while now. Just remind me again, what did we learn at the primary 12-month outcome?
Well, importantly, non-inferiority was met for both endpoints. So we had really an excellent efficacy result with a primary patency of over 80% in both groups. And this was paralleled by a primary safety with freedom from these major adverse events over 90% in both groups.
And then just recently at Link 2021, you presented updated 24-month data from the COMPARE randomized trial. What did you actually tell us?
It was really impressive. When we looked at the Kaplan-Meier curves for primary patency, these curves were almost overlapping. So that was really quite remarkable as they looked so identical. What's also interesting in this trial, we included also long lesions up to 30 centimeters, and we had a stratification for lesion length in this trial. So when we looked at the individual subgroups, lesions below 10 centimeters, 10 to 20 centimeters, and 20 to 30 centimeters, we really found reassuring, very similar Kaplan-Meier curves for both groups in each stratum. So, which tells us that actually this treatment effect, or this comparable treatment effect, is seen over a long range of lesions. I mean, what was important, of course, and it's also reflecting real world, that we really saw a substantially higher bailout standing rate in the long lesions. So in the short lesions, we started with around, let's say, around 12% bailout standing rate, which went up to around 25% in the middle length lesions, and was almost 50% in the long lesions. So this is quite something we also saw in registry data from other DCB trials, I would say.
And so what about safety? How did the devices perform from a safety standpoint?
From a safety standpoint, I think it's really important that we had a very low all-cause mortality in both groups. It was around 2 to 3%. Also, for the other key secondary outcomes, endpoints, we only saw one major amputation very late on. And also freedom from clinically driven target lesion revascularization was over 80% in both groups. And of course, there was no difference between the groups. And this was really paralleled by a sustained clinical improvement and also hemodynamic improvement of around 70% in both groups. So I think this is also quite reassuring safety data.
And certainly when you devised the COMPARE trial, little did you know the controversy of paclitaxel that was going to emerge.
Absolutely.
But now we're coming out of that cloud, certainly with the presentation of the Voyager data last fall, the publication of the SwedePad study in the New England Journal earlier. I think we recognize that this data further supports the safety of paclitaxel. So we're at 2 years. That began the window of concern for paclitaxel following December of 2018. And yet the mortality rate was low in both groups, as you said, and much lower, frankly, than what was seen in the SwedePad study.
Absolutely. I mean, we did not include patients with ischemic wounds, so we had a little bit of different patient population, I would say. We also looked in our trial actually at pharmacoprotective therapy, which was pretty good, and I really have to congratulate here the German centers. But it's really important that we have this low mortality rate. It's just reassuring, as you've said. And
certainly at Boston Scientific, we're continuing to study the role of drug-eluting devices in peripheral artery disease. The Imperial trial follow-up continues. The Ranger randomized trial continues. COMPARE, obviously, our announcement of the Elegance International 5,000 patient registry, in which investigators will be able to choose either Ranger or Eluvia for their patients, and our commitment to include at least a third to 40% of that population being underrepresented minorities, so that we can actually learn how to treat those patients who routinely are not in clinical trials. So again, very exciting. Congratulations on this incredible work and your continued meteoric career.
Thank you very much. It was really a pleasure and a great honor. Thank you very much.